Can we start my presentation? So, just raise hand if you can hear me. Okay, great. So, my theme today is to talk about what has evolved in the nerve-sparing robotic radical prostatectomy. Because in the last over 20 years, I have been working on nuances of how to make this procedure a little bit more precise, more delicate, and more individualized. And that is the theme I will be presenting you. It has come a long way from 2003 when I first published a paper about neuroanatomical foundations of robotic radical prostatectomy. We do know that nerves are quite complex and they are around the prostate like in hammock. They are not simple one nerve or one neurovascular bundle. And that appreciation led us to develop a model that's a 3D model which gives us a summary of how nerves are arranged around the prostate, how different facial layers are encasing them, and what as a surgeon we have to do to get the cancer out, yet not impact the nerves either physically or physiologically. And that is the theme you will see. I'm not going to spread too much of a time on this neuroanatomy model, but I do want everyone to appreciate that robotic radical prostatectomy is many different operations for many different patients. A patient with a Gleason 7 prostate cancer who has a minimal disease, who has no encroachment on the capsule, is a candidate for what I did on the right side yesterday, what we call a grade 1 nerve sparing, where I'm hugging the capsule right at the edge. But sometimes you have a risk of extracapsular extension. You cannot be sure, so you have to tailor the surgery based on that individual patient, and you leave some tissue on the specimen. And in my case, what I call a grade 2 nerve sparing, in which I'm leaving the venous structures on the specimen, and there is an example how it has been done. Then if the risk is higher, you leave more tissue on the specimen, and we call it as an incremental nerve sparing, grade 3s, and if sometimes you don't do the nerve sparing. Based on the MRI, based on the different imaging modalities, we have put together nomograms which predict likelihood of extracapsular extension, and it also gives you a number what grade of nerve sparing is appropriate for that particular side of the prostate. It's so a side-specific image-guided nomogram. We have, in last few years, have been dealing and experimenting with a new kind of an imaging modality that's in surgeon's hand, what we call an exact view. Exact view is in 29 megahertz micro ultrasound that gives you a very high resolution pictures of the prostate and also shows you where or if there is an extracapsular extension. We have put together a nomogram for that also, that you use the information from a micro ultrasound and put it together, and then you can tailor the surgery for left and the right side. So up to now, I just laid down the foundations that the nerves are there, they are complex. You cannot do the same surgery in everyone. You cannot do the same surgery on the two sides of everyone. And now next concept is that of how to preserve continence. And a lot has been learned by Dr. Buchardi's approach about the ridge sparing surgery. Basically, saving the structures which are anterior to the prostate, and they can have a major impact on recovery of urinary continence, and definitely in terms of how soon it will happen. Many modifications have happened, and me and Francisco have been working on this for a long time. I call it as an hood technique, that the anterior structures can be saved without us getting through the pouch of Douglas, which is a little awkward and forces us in a narrow space getting to do the nerve sparing and save the structures anteriorly. It makes the bladder neck a little bit more challenging and the anastomosis a little bit more challenging. So we wanted to gain the similar benefit that of ridge sparing surgery without getting through the pouch of Douglas, and it can be done anteriorly, and then we both have figured it out how to do it, and a lot of the people are adopting to it. We call it as a hood technique, and hood structures are in front of the prostate, and we can save them without making our life a little bit complicated. Hood technique can be done in many different ways. You can make the bladder neck bigger if there is an issue with the median lobe. You can make the bladder neck bigger if there is a base cancer. You can make the bladder neck bigger if there is an invasion of cancer at the base in the bladder neck. Or you can make the bladder neck small, just the way you would normally do it. And I'll be showing an example right here as to you can very precisely save a smallest bladder neck that is possible in a right patient. And knowing about the right patient is the art of making a decisions in urology, and you use the information about the biopsy, you use the information from the MRIs, and you use information from cystoscopy sometimes. But basically, if you have a right patient in which the cancer is away from the base, away from the bladder neck, there is no median lobe, there is no other issue, you can save a small bladder neck. And here, what you are seeing, I'm developing a plane in front of the prostate, but not going too close to the pubic bone. All the fatty structures and everything is still going to be on this specimen. I'm getting in front of the prostate, and once I have the front of the prostate exposed, I will try to find the right junction between where prostate ends and where the bladder starts. That usually is a junction where fat, if you are stripping the front of the prostate from the fat start getting a little bit more sticky where bladder starts. So that's a cue to you to identify where that junction is. So you go a layer by layer. So I have a very fatty, chunky hood in this patient, but I'm getting underneath that. Then I will try to find the junction where prostate and the bladder are joining. I will tease the tissue away from bladder towards the prostate to finally find a narrow bladder neck. I hope you can appreciate in this video. And slowing it down in this process is important because this will allow you to find the right junction. Otherwise, you can always make a bladder bigger without much of a problem. But in order for you to be a precise in a small bladder neck, you have to invest some time. I was very happy with yesterday's case that even though that patient had a couple of TURs, couple of thermotherapies, all the inflammation, extracapsular extension, we got what we planned to do in that patient without much of the compromise. It was not going to look very clean because the tissue was not very helpful. He had a high BMI, but we got what we needed. It was a medium-sized bladder neck right there, and even prostate and even the trigone was little inflamed, as we could appreciate. Similar thought here. Now I'm at a junction where I am trying to gain few millimeters of urethra right here. If we spend time, this is a kind of a bladder neck we can get. You have always got to be a little cautious that there may be a nubbing of BPH, not a cancer, but a BPH tissue there. So spend some time on that. Now I'm going to show you where I start on vas and seminal vesicles. If you are on the right plane and the tissue is not burnt before or not very inflamed, you can find the planes in front of vas and seminal vesicle. I usually go after the right vas first. I will find a stump of the right vas. I'll spend some time. This is a semi-live, so I'm spending a little extra time letting the video run so that you can appreciate it. Right about that time when I'm ready to cut the right vase, my assistant who was there yesterday will grab the distal end of that vase. Then I will go after the left vase difference. And everything is being done anteriorly. I have not entered the pouch of Douglas so far. I hope not. Once the second vase is up, both vases will be transferred on my fourth arm. So at this point, left and right vase are identified and they have been lifted up. And I think it jumped through. So now after vase differences are up, I'm going after doing the nerve sparing. And this is a case where I'm planning to do a grade 1 nerve sparing. Essentially, it means that I'm hugging the capsule and I'm less worried about extracapsular extension discussion. I will open up the denon-villus fascia just below where seminal vesicles are attaching to the prostate. I will try to find the right plane. There are many planes you can find even posteriorly. Here I'm trying to find the plane which is very close to the prostatic capsule. There are no nerves which are coming in the midline, so I basically try to develop the plane as far as I can in the midline and then slowly march laterally. I will go as far as I can. This is where you have to spend some time, and if tissue is not inflamed, you are lucky. You can find those layers one at a time, and you can choose which layer you want to be in this particular case. Sometimes, because of the biopsy or because of thrombophlebitis, you can find that some vessels and things are stuck. Spend some time, because if you try to bluntly dissect that, sometimes it will open a flap. In this case, it is opening up all right, so I'm continuing it slowly but surely. Then you march laterally a little bit, and as I say, this is in what we call the micro-zapping. If there is in small blood vessels, you can see it. You can go through that. Either you can cut it coldly, or you can control it either with a clip or within cautery, depending upon how big that blood vessel looks like. Then you slowly march on the lateral aspect. I try doing left side first if left side is not complicated. Yesterday's case, there was more inflammation on the left side, so I didn't do it in the beginning. I took some time. I will finish the nerve sparing part. I will dissect the planes between the capsule and the neurovascular bundle, and if you get lucky, you will get into this plane, which is just outside the capsule, and then you lift it up, the hood will separate, and this is all the structure, what we call anterior, lateral, and anterior. Here you can make a decision whether you can use cautery or you can use cut, sharp. You can use a suture before. So I'm doing as far as I can, and you can see a lump of tissue a little bit on the right side. Most likely it's a BPH tissue. If you are worried about that there could be a more grade 2 kind of a setting, then I can choose to leave a little bit of a tissue on the specimen, and you can appreciate that using a sharp scissors, you can make a subtle adjustment and not make a blunt dissection, rather leave few wisps of the tissue there and hoping that it is enough. Next thing, I want you to appreciate that not every patient is a case for a grade 1 nerve sparing, meaning there are patients in whom you will find that there are extracapsular extensions, bulky mass, you are really worried about it, and you can see the MRI there, that there is, and most likely there is an extracapsular extension there. So here I want you to appreciate that it is possible to understand the concept of what we call layer within the layer. Lateral prosthetic fascia is not a unique compartment, and with experience you can find layers within the layers, and I'm showing you in a real patient that how those layers can be appreciated and developed slowly but surely. I hope you can see that there are more than one layers right here, and it is possible to dissect it out if the anatomy is clear. This thing can be done even easier if I can share with you my concept of what we call an hydrodissection. So I introduce a concept of complexity in the nerves, and then that there are layers around the prostate. How to find that layers? Sometimes patience and sometimes help of water. So that's what Dr. Mathri was demonstrating yesterday. We have been working on this project for some time, and you can find layers with little bit of an hydrodissection, especially in a case where you are a little concerned about the extracapsular extension. Hope you can appreciate this. So using a very delicate needle and then water, you can develop planes around the prostate outside the capsule. So lateral prosthetic fascia can be opened up into different layers using water as a guide. And when you are using water in that compartment, the first thing which floats away from the prosthetic capsule are the nerves, because they can move. Blood vessels are more stuck to the prostate. So here I'm developing the plane. So you saw the one plane, and then suddenly with the hydrodissection, capsule and the tissue becomes very different in texture. Now I'm developing the second layer. The first layer has been developed, I'm developing the second layer. And in this case, I can really say that I will be able to show you the nerves in as clean a form as it is possible. So I'm in a grade 2 to 3 layer right now, and the nerves are going to be exposed in the next few seconds. Can you see the nerves now? If you can just, I cannot hear you, but I can see you. So these nerves are now exposed. We can see that we have not damaged yet. In this case, I'm worried about that there may be a higher likelihood of extracapsular extension. So as long as though I don't expose the capsule and I leave these nerves intact, I achieve the both purposes of getting a negative margin, yet saving as many nerves as we can. We can save most of the nerves on a grade 1 approach, but I didn't get to that patient 2 years earlier, then the cancer would have been intraprostatic. So what we have now, we can deal with it. And I'm trying to show that with the delicateness and with hydrodissection, you can expose the nerve and then save it under vision. I also want you to see that this hydrodissection can be done real-time, intraoperative, using an micro-ultrasound, and you can see that I'm opening up the plane outside the capsule with a needle in a real time. It is very easy to do it when you're doing the surgery, and we have been doing combination of intraoperative, transperitoneal, or transrectal, or transperineal. You can use the plane, and then suddenly you see tissue bloating up in front of your eyes. I will show you a little bit more of the hydrodissection here. This is on the other side. So basically with this approach, if I'm doing the grade 1 nerve sparing at 1 year, close to 90% of the patients can get erections back. And even in some patients who have an extracapsular extension, you can get sexual function back in maybe about 65 to 70% of the patients. That is a major achievement, and the continence results are pretty close to what we have been getting with the radius sparing approach without compromising the space, without compromising the median lobe discussion, without compromising tailoring the surgery based on in particular patient's own variables. And I think we have tried this approach in many different ways. We have done large median lobes. We have done Gleason 9 cancers. We have done up to 426 gram prostates. And we have done in the patients who have an invasion of the bladder neck because of cancer, we had to cut very closely. And that's exactly what I was mentioning yesterday. Do I need to put in a ureteric catheter? I can do all that in an anterior approach, what I'm just mentioning. So in a nutshell, what I showed, that understanding the anatomy was a foundation. Appreciating that there are layers within the periprostatic tissue is important. Understanding that not every patient needs the same operation and you have to tailor it, and tailoring starts before getting onto the operating room, beforehand. If the planes are not opening up easily, you can take help of hydrodissection. An anterior approach gives you a unique opportunity to do this operation without much of an hassle and getting all three goals done. That is to get the cancer out, to get the urinary control soon enough, and still manage to save the nerves. And in right patients, you can get really very good results at the end of 1 year. Thank you very much.
Thank you very much, Ash. You are amazing. It's not the first time I listen to your lectures, but you keep always putting the bar higher again. Thank you. It's really a pleasure to listen to you. Do you have any questions?